Professor and chair of the recording. Professor in political science at Dalhousie, has a cross appointment in community health and epidemiology. She's the director of the Jean Monnet Network for Health, Law and Politics, funded by the European Union's Erasmus Plus program. And Dr. Fierlbeck focuses on the politics of health policy, particularly issues of governance and mechanisms of accountability. So I hope that this the topics that we're interested tonight come under your umbrella. They sure seem to for me, and I've heard lots of great things from Maddie, and her partner, I believe, is associated with your research as well. So so thank you for being here. The first part of this will be us listening to you for about, what's that, about an hour or so, Katie, and then we'll have a quick break, and then we'll come back for a facilitated discussion. If we have some prepared questions to get a discussion going. And if anyone has questions they want to jot down and submit, Katie, what's the best way to submit? Via chat or?
Yes, via chat, and Sam will be able to read them out on your behalf.
Yeah, and we probably won't get to every question. We'll try to scan through the ones that are most sort of interesting, relevant, or not repetitive, that sort of thing. So without further ado, thanks so much for joining us, Katherine, and over to you.
Okay, thanks so much, Jason. Now, can everybody see my slides? Can I get a nod or a thumbs up? Excellent. Okay, so I actually just noted that the subtitle of the advertised talk here was Shades of Gray. And while this is not at all inaccurate, I just want to say that I'm glad the word 50 was left out in case people thought the talk was going to be a bit more entertaining than it actually is. And if I were to give it a subtitle, it would probably be more along the lines of God and the Devil are in the details. So I want to begin by thanking you for the opportunity to discuss this subject. And I know that the quickest way to lose an audience is to say, let's start by defining our terms. You know, you generally want to begin a talk with something like, did you know that an asteroid is about to hit the Earth? Rather than asking, what exactly is an asteroid? But in this case, I'm going to go against my own advice. Much of the following discussion will focus precisely on what we mean by private healthcare. The healthcare system, as you are very aware, has a number of quite distinct component elements. So we really need to be, we really need a clear sense of what precisely it is that we want to privatize and for what reasons. And with what consequences, because it's really not a one-size-fits-all issue. And moreover, as I hope to show, because the private part of private healthcare can mean so many different things, rhetorical bait and switch tactics are often employed in policy discussions. So, for example, a lot of the rhetoric over private healthcare goes, well, it seems to work just fine in Europe, so why don't we do it here? But of course, it's not the European model of private healthcare that Brian Day of Cambia or Adam Hoffman of Algomet are pushing for. They're really advocating for the American model of private healthcare, which is quite distinct. So I want to do three things in the next hour. First, get a bit into the weeds and to dissect exactly what is meant by private healthcare. And don't worry, this part is short. And if it gets a bit too tedious, please just feel free to check your mail or to grab a cold beer from the fridge or something. Second, I thought we could discuss how private healthcare works in healthcare systems that are generally highly rated. And then third, I want to discuss in more detail what private healthcare means in a Canadian context. So what is meant by public and private healthcare? So public discourse is often structured as if there were two, mutually exclusive options. Sure, we have public healthcare or private healthcare, which is really about as helpful as saying that, health and sickness are two mutually exclusive options. So conceptually, we can probably put this on a spectrum and maybe put public on one end and private at the other, which is slightly better. But again, it's quite unidimensional. I mean, after all, one can be healthy in some respects, but not in others. Your heart and lungs could be in great shape, but you could have a bad rash or a broken leg. So for healthcare as a system, we normally try to distinguish aspects of the system, and the two basic axes are normally funding and provision. So now we have a quadrant model. And in the schematic, we can have services that are both privately funded and delivered. So, for example, paying out of pocket directly to your GP or your ear, nose and toes specialist, or you can have both publicly funded and publicly delivered healthcare. So, of course, in this case, your taxes go to the state pays physicians a salary, and Bob's your uncle. In Canada, of course, as you know, most of our services are funded publicly, but provided privately, although, of course, we also have forms of healthcare that fall into other quadrants as well. But even this is simplistic. Healthcare systems are designed not only on the basis of funding and provision, so on the two axes, but also very importantly on how they are regulated. So we actually have three dimensions, right? There's three types of funding: state, market, and social insurance. There's three types of provision: state, private interests, and not-for-profit groups. And I just want to say, I've worked with physicians before, and when I put NFP, they say natural family planning. So I just want to say here, NFP in this instance is not-for-profit. And the third dimension here is types of governance. So whether it be by the state, market, or private not-for-profit groups. So if you look at all the different combinations, you end up with a possibility of 27 different kinds of healthcare systems, and here they are. And as you can see, if you squint, perhaps most of them involve some element of private care, if we include both private for-profit and private not-for-profit in service provision and regulation. And yet each of these is a different system where the private component is manifested quite differently. Now, others have argued that you actually have to rank order these dimensions, and if, as they argue, you begin with the way in which a system is regulated, then I'm sure you'll be happy to hear, you end up with only 10 different plausible kinds of systems. Now, even here, almost all of them still involve some component of private healthcare. Now, I don't want to belabor the point. If for any reason you want to read through this discussion, if, for example, you have a hard time falling asleep at night, then I can provide the article references for you in the chat box. The point here is simply that it is not helpful at all to talk about private healthcare as a generic absolute, right? We have to be very specific in what we mean when we talk about private healthcare, because privatizing different components will have different impacts depending upon what exactly is made private, under what conditions, and what we mean when we say private in the first place, which again is, as you've noticed, why I have the annoying habit of using bunny ears so often when I talk about private healthcare. So just to make this less abstract and more concrete, let's look at one example of a high-performing private healthcare system that is often referenced by those like, those at Canby or Algmed who espouse more private healthcare in Canada. So it works great in country X. So why are we so hesitant in accepting private healthcare? So let's look at how private healthcare actually works in a system that actually has been getting fairly good reviews. Now, I just want to say that on CBC Radio's program, The House this summer, the CEO of Algmed, Adam Hoffman, was interviewed, and he made the point, as have many others, that the Netherlands, one of the most highly ranked healthcare systems, is largely private. So why are Canadians so gosh darn precious in refusing to consider private healthcare? And this argument is quite common, as you can see here and here. Our friend Andre Picard weighs in here as well, and even here. And by the way, I just want to say that this statement is factually wrong. This is just a person from Ontario assuming that's what is true for Ontario is true for all of Canada, but in fact, it is not, as we shall see in due course. So the Commonwealth Fund's ranking is one of the best known health system ranking scales, and I'm sure you've heard of it. And for several years, Canada has been sinking downwards, and now it has the lowest overall ranking, except for the US. Thank heavens for the US, which has been in the bottom spot ever since this ranking was created. Norway currently holds the #1 spot, but as Norway has that spot, at least partly due to being a small population enjoying high oil revenues, I thought it wasn't a great comparator. But the Netherlands, which reorganized its healthcare system in 2006, is second on the list, and it has a significant private healthcare component. And notably, as you can see, it's also #1 in terms of access to care. And moreover, the Dutch are actually relatively happy with their healthcare system, although no system is without its critics. So the Netherlands seems to be a paragon of private healthcare, according to a number of media articles. So is this not something that Canadians should at least consider? How do the Dutch achieve superior healthcare? Okay, so what I'm going to do, just to make this as simple and as quick and dirty as possible, is to start with an avatar whom we'll call Marika. Okay, so how is she covered? Well, she pays about $2,000 a year. Now, I'm using Canadian values here. I've switched from years. So $2,000 a year in healthcare premiums every year to her private, not-for-profit insurer, a sickness fund. Now, the state mandates community rating, so everybody has to have private insurance and they pay the same. Now, the state highly regulates these insurance companies. It requires that everybody pays the same premium, regardless of health status. It regulates which services the insurers are expected to cover. It regulates the level of coverage and so on. So those who can't afford to pay the premium are subsidized to various levels by the state. And about 30% of the population does receive some assistance in paying the premiums. Now, Marika and her employer will also pay a payroll tax of about almost 7% of her income directly to the state. And Marika's brother, who is self-employed, just pays a direct 4.85% healthcare tax directly to the state. Now, Marika also pays 9.65% of her income into a long-term care fund to support her comfortably in old age. Now, the Dutch, as you probably know, have one of the most sophisticated systems of long-term care in the world, but they also pump a lot of money into it. Now, because different sickness funds are required to cover everyone at the same premium, there is also a process of mandated risk adjustment between sickness funds every year through a pooled health insurance fund to ensure that the costs of insuring more expensive patients are distributed more evenly across these private companies. And the state also pays the premiums for children under 18 directly from this pooled health insurance fund. Now, in exchange for this, Marika enjoys free point of care access from her GP. However, should she go to the hospital, including emergency services, or if she gets a diagnostic test, she has to pay a $500 deductible per day or per visit, depending. She could also agree to a higher deductible in exchange for lower monthly premiums. And while her prescribed drugs might be partially covered, there may be a copay depending on the effectiveness of the drug. So there's a reference pricing system, and other items she may need are not covered at all. So like 84% of her compatriots, she also has private voluntary insurance, which is risk adjusted for each person, which costs her about $400 or $500 a year. It covers things like dental, optometry, physiotherapy, some drugs, and so on. And she may also have some out-of-pocket costs as well, as her private voluntary insurance may require copays depending on her plan. Now, this really is a bare bones account of how the Dutch system works. It's far more complicated than this, but it does allow us to make several observations about the nature of the private aspect of Dutch healthcare, which again is fairly good. I mean, you can see her smiling, right? She really likes her healthcare system. But things to note. First, the Dutch system is only private on a particular interpretation of the word private. The health insurance companies are in fact private, but they are run as private, not-for-profit agencies, and are in fact heavily regulated by the state. Again, the state mandates the purchase of health insurance. It mandates what the companies must provide. It mandates how much the coverage is to be provided, how much coverage is provided. It mandates what healthcare providers can charge. It mandates the level of quality of care and so on, and so forth. So there's a lot of regulation. So when people like Brian Day or Adam Hoffman argue for a private healthcare system, I'm pretty sure they're not talking about a heavily regulated not-for-profit model. Another point, the Dutch system also has voluntary for-profit health insurance, but it largely plays the same role as it does in Canada. It covers eye exams, physio treatments, and so on. Now, it is true, as Vox reported, that there is a kind of market competition, get my bunny ears into the screen here, which is used by the Dutch healthcare system. But in this kind of a faux market, which is technically called a regulated market, health services are not available to all on the open market. It's more of a system of managed competition, which is also called regulated competition, which was famously imposed by Margaret Thatcher on the NHS in the late 1980s, without any warning to her cabinet, thus bringing the verb to be handbagged into the English language. So basically what happens here is that the insurance funds, the sickness funds, will shop around for healthcare providers who can give more competitive rates. And again, it's based on a system much like diagnostic related groups. But it's not at all the kind of free market system espoused by Brian Day et al. So yes, the Netherlands, the Netherlands does have a very private system, but you really have to understand what is meant by private. Should Canada emulate this kind of a system? It does have a lot going for it. Universal coverage, good access to care, high patient satisfaction, good quality, reasonable equity. So if you were to tell me, looking into a crystal ball, that Canada would have a Dutch-style private system in 10 years' time, I probably wouldn't lose too much sleep over it. But the real question is this something that we want to go out of our way to adopt? Because, as you might anticipate, there are a few downsides. It is one of Europe's most expensive systems. People like their healthcare system, but they pay a lot into the healthcare system. And there are also very high administrative costs because of all the regulation, because of the risk pooling. And a system of managed competition requires a very sophisticated system of pricing the cost of treatments, as well as a solid HTA system to determine what kinds of treatments offer the best value for money. So if you want to implement a system of managed competition, the cost of setting up the infrastructure needed for it to work is actually fairly high. As we've seen, the Dutch system is incredibly administratively complex. So a huge amount of time and resources are spent on trying to administer the system. If you're familiar with the French system, it's probably not as bad as the French system, which is, I think, even more administratively complex. Now, also, as you may be interested to know, healthcare providers get paid a lot less. Now, I was looking at a report from, I think, 2020, so it's not too out of date. They list the gross annual earnings of GPs at, in Canadian values, $177,000 a year, which, as far as I know, is even less than what GPs get in Nova Scotia. And I hear less than half of what GPs in BC will be getting. At the same time, gross annual earnings of specialists are run around $210,000 to $376,000 Canadian. So basically, if you pump more money into the healthcare system as a whole, but you pay your providers less, then you can afford a lot more care for the patients. But is that politically viable in Canada? And I'd love to see some of your expressions if your cameras are on. Few equity issues. So while there is universal coverage in the Netherlands, there is nonetheless pressure to alleviate costs, which tend to fall on the backs of the less well-to-do. Because the Dutch system is so expensive, it has more recently doubled down on cost containment. And how do insurance companies deal with rising costs? Well, by delisting services and by increasing deductibles and copays. So as you know, hospital stays, including emergency care, have a big deductible. So if hospital stays and emergency care requiring deductibles and copays have adjustments, these adjustments meant to contain costs are going to hit the less well-off more. So according to a recent analysis of the Dutch healthcare system, and I quote here, there is evidence that the introduction and increase of the mandatory deductible since 2016 has had a negative influence on access to healthcare. At the same time, as more services are delisted, fewer people can afford voluntary coverage, which has dropped from about 93% of the population down to about 84% of the population. And given since we're all still obsessed with COVID, there is the observation that market systems or competitive systems don't serve public health well. According to the same report, COVID has shown that competition fails to work in the context of a pandemic. And they say, given its strong emphasis on efficiency, competition fails to build up a reserve capacity that can be quickly mobilized. Building up such a capacity is a public problem that must be addressed by the state. Okay, so there's pros, there's cons. What should we make of this example? Well, the first point is that the way in which the Netherlands incorporates private healthcare differs substantially from an American-style market-based system of healthcare. So do not confuse the two. Be careful for sleight of hand when you have policy discussions. The second related point is that for private healthcare to work well as a system, it might have to require a lot of heavy regulation by the state, right? And that's the catch-22 that advocates of private healthcare like Day and Hoffman in Canada refuse, I think, to acknowledge. Now, some have argued that when evaluating healthcare systems, rather than simply asking the extent to which they are private or public, it's far more helpful to ask the following questions: who's covered, what services are covered, and what proportion of costs are covered? So basically, if some form of a private system can get you to a bigger gray box, then who cares, right? So a different way of conceptualizing whether a system is working or not. Well, very briefly, the third point I want to make regarding this comparative example of the Netherlands, is that in policy analysis, just as in the bench sciences, we have to remind ourselves that correlation is not causation. And just because we have two variables coinciding, it doesn't mean that one necessarily causes the other. Now, we can chat about this in more depth later on, but I would suggest that some of the most effective practices in Dutch healthcare, the reasons why it is so well regarded, in fact, have very little to do with private healthcare per se. Okay, so here we come to the bit that I think that people actually signed up to hear. Again, however, it involves some definition of terms for which I apologize, but at least I don't think there are as many bunny ears in this section. Now, the debate over healthcare privatization in Canada focuses on two quite distinct things: private insurance, which was the subject of the Chowley Charter Challenge in Quebec, and private provision of care, which was more recently discussed in the Canby court case. There is also the debate about P3s, but that generally addresses capital costs, so let's just set that aside for now. Okay, private health insurance. So again, we have to be careful to distinguish exactly what we mean by private health insurance. So in the first place, we have social health insurance, which is comprised of contributions from employers and employees, and which is generally run by private not-for-profit entities. Now, because it provides a universal social benefit, and because it is highly regulated by the state, it is formally considered to be a kind of public health insurance. So all international statistical agencies such as OECD or the World Health Organization classify social health insurance as public. Actually, we do this in Canada as well. Remember that workers' compensation is 100% paid for by employers and is governed by private not-for-profit bodies. And yet, if you look at the CIHI stats, CIHI counts it as a public or a social healthcare program. So remember that any figures you see comparing how much public versus private financing any healthcare system has will generally categorize social health insurance as public health insurance. So CIHI, for example, tells us that Dutch health care is 83% public and 17% private compared to Canada's 70-30 split. So this is not what the political debate is about in Canada. I mean, nobody's really asking for social health insurance as it performs the same function as a public tax-based system. Now, we actually have this in Quebec, but it's only for pharmaceuticals. Then we have supplementary health insurance, and this is private voluntary insurance that covers those goods and services not covered by public insurance or social health insurance. So again, dental, optometry, physio, drugs, and so on. And it's generally risk adjusted. So the less healthy you are, the more you pay. But again, we already have this in Canada. About 13% of health spending is via private health insurance. So this is another non-issue. In countries like France, we have a widespread system of complementary private healthcare, which covers most of your regular copays or premiums or co-insurance. So as a French resident, if you go into the hospital, your social health insurance will probably pay around probably about 80% of the costs, and you make a set copayment, maybe about $30 on top of that, which your voluntary complementary insurance, if you have it, will cover. Now, not necessarily completely. So the French often have a symbolic €1 payment that has to come out of pocket. It's complicated, but again, given that we have 100% coverage for services that are publicly covered, complementary insurance really is not really relevant to the discussion. In Germany, we have a system of substitutive health insurance, which means that if you're rich enough, you can, if you prefer, completely opt out of social health insurance and be completely covered by private for-profit insurance. So rather than the doctors opting out of the public system in Germany, the patients do. Now, as you know, the huge debate in Canada is about duplicative or dual. Dual is easier to say than duplicative. It's the same thing. Duplicative health insurance, in which you can get private insurance to cover things that are already covered by public insurance, but you can get them faster or you can get them better. However, in order to get them faster, you also need private providers who will take your private insurance. Now, this was the substantive issue underlying the Shaoli Charter Challenge some years ago, with the impugned piece of legislation being Section 15 of Quebec's Health Insurance Act. So here's how it looked pre-Shaoli. Now, they also addressed Section 11 of the Hospital Insurance Act, but have a look at this pre-Shaoli section, and then here's how it looks post-Shaoli. Quebec now permits duplicative insurance for hips, knees, and cataracts, as well as various services supporting these procedures. So Quebec has duplicative insurance. So what What consequences does this have for wait times for hip, knee, and cataract surgery, which they allow? Okay, so here we have two provinces where dual insurance is legal. So how well do these provinces perform? And I just want to say that, yes, we don't have duplicative insurance in Nova Scotia, but it is legal. So just as a benchmark here, we can see that the figures on hip replacement, knee replacement, they're even a little bit worse than those in Nova Scotia, though cataract surgery a little bit better. And here we have two provinces where duplicative insurance is actually illegal. So illegal here, and the wait times are notably better, both in Ontario and British Columbia. Okay, so simply allowing duplicative insurance that isn't a simple or straightforward means to improve access to healthcare. It's not a magic bullet. Okay. Well, what about private providers? As you know, the majority of physicians in Canada technically are private providers already, which was a settlement made as a condition for accepting Medicare in the 1960s. Most provinces, again, already contracted private clinics to provide certain services paid for directly by the province. And in Nova Scotia, that includes Scotia Surgery and now Maple, which provides virtual healthcare. And the key here is that patients can't access this form of care directly. They have to first go through the public system, and they aren't charged directly at point of care for the service. Now, here's where things start getting complicated. So, what's actually standing in the way of private healthcare in Canada? Well, again, it means it depends what you mean by private healthcare. Is it the Canada Health Act? Well, every so often you find an op-ed arguing that we have to reform the Canada Health Act in order to allow for private healthcare, right? Well, sort of, but not really. The only things that the Canada Health Act actually forbids are user charges and extra billing. And you can find those in sections 18 and 19. Now, beyond these two things, provinces can have as much private healthcare as they want. And technically, provinces can also legally allow user fees and extra billing if they want. It's not illegal per se. It's just that any user fees and extra billing charges will get clawed back from the federal health transfers. And most provinces want those health transfers, so they will voluntarily make user charges and extra billing illegal, so they don't have to pay out of their own coffers. So the first point that I really want to emphasize is that most of the constraints impeding private healthcare provision are all set in provincial legislation, except for these two. And even so, if provinces really wanted to allow for this, they could. It's not illegal. They just would get penalized in terms of deductions. So the Canada Health Act is silent on everything else beyond user fees and extra billing. Yes, I know the principles of the Canada Health Act do set out a publicly insured system, but the principles of the Canada Health Act have nothing directly to do with private health care per se. So, for example, the principle of public administration does state that you have to have a form of public insurance, but it doesn't say that you can't also have private insurance as well. So the provincial legislation varies from province to province. So the Canby case in BC, for example, challenged not really the Canada Health Act, but more importantly, the BC Medicare Protection Act, specifically the sections that require physicians to be in or out, that prevent private fees exceeding the public fee code, and the ones that prohibit private insurance for publicly insured services, all of which are under the provincial domain. So this is why the issue of private healthcare gets so complicated so quickly in Canada. This being Canada, most healthcare legislation is provincial, and all provinces approach this matter slightly differently. Ontario has amongst the most stringent legislation in Canada, and most people assume that what is the case in Ontario applies to all of Canada, but it doesn't. Let's go back to our friend, Dr. Charles Schaefer from Ontario, Canada, and who also claimed in his op-ed in the Chronicle Herald, and I quote here, "The Canada Health Act does not apply when one obtains private health care in a different province." Now, he was writing this for a Nova Scotia audience. Well, there's nothing in the Canada Health Act that says it's okay to get private services done in another province. This may be a way of doing an end run around provincial legislation in Ontario, but it's got nothing to do with the Canada Health Act. So in Nova Scotia, as well as some other provinces, there is no explicit prohibition against offering private insurance for publicly insured services. So physicians here can opt out of the public system, which they can't do in Ontario unless they were grandfathered in from before 2004. They can accept private health insurance for services covered under public insurance, but they can't charge more for services than what is set out in the provincial fee code and under sections 27, 28 of the Nova Scotia Health Service and Insurance Act. They have to be either in or out of the public system, not both. So what this means practically is that private physicians in Nova Scotia would have to have a huge volume of well-heeled clients in order to make a living, which is kind of difficult in Nova Scotia. But it's not inconceivable in larger and wealthier provinces, which is why that is where the pressures for greater private health are. In larger provinces, physicians can actually make a living in the private sector, even given provincial statutes making it difficult to practice privately, but they could make a much better living if they were not constrained by various provincial restrictions. So let's unpack this in a little bit more detail. Now, this might be the most useful visual in this talk. And just a disclaimer here, I've culled the data together from a few sources. Some bits may possibly be out of date, but I think they're pretty accurate. Okay, so let's begin with the number of opted out physicians. You can see here that the biggest push for private healthcare comes from the largest and wealthiest provinces. And the data for this column is largely taken from the Canada Health Act Annual Report 2021, which requires provinces to self-report certain kinds of information. And it's worth a read. Quebec hates doing this for obvious reasons. And in fact, it stated in the last report, well, if you really want this information, just go and look on our website. We don't have time for this, which is what they say here in much better language, but that's what they say. They don't give this information. They say, check our website. One of the figures that they refuse to give is the number of opted out physicians. So I got this figure from an article by Contandriopoulos in Law from about 2019, I think. So the figure is pretty significant. You can also find more recent information from the Quebec Official Gazette, as the number fluctuates over time, although they don't make it an easy search. I tried to do it this afternoon, but you have to dig down into it. Ontario, of course, by law, does not allow physicians to work outside of OHIP, except for those who were there before 2004. Okay, number of private for-profit facilities that actually provide services that are covered publicly. Now, interestingly, Health Canada doesn't tell us exactly what we want to know, which is how many facilities are there providing health services that are also that provide private services that are also covered publicly in Quebec, Ontario, Alberta, and BC. Now, there's likely some methodological reason that they don't give this information, but most won't say what it is. Ontario said, oh, we just don't collect the data. Saskatchewan, don't get excited by that. In Saskatchewan, CT and MRI services are not considered insured services within the meaning of the Saskatchewan Medical Care Insurance Act. So these are just diagnostic facilities. Now, I don't know what this one Newfoundland facility is. So if anybody knows the Newfoundland landscape, please fill me in. Now, according to Health Canada, then Nova Scotia had no private healthcare facilities in 2020-21. If by private, we mean facilities that provide private services that are also publicly insured. Now, it would seem not to include Algomed, which was set up this past summer, So when the next report comes out, we may have a different number. Now, what is kind of interesting here is that Algamed does offer duplicate services, but only primary care services. So, for example, no joint replacement, but it has no opted out physicians. Now, I double checked this in September with MSI, and they confirmed at that point there were no opted out physicians. So how does Algamed do it? Well, we know it's staffed by nurses, and the nurses, and I asked them, they're under the supervision of, and they said it could be nurse practitioners or doctors, by which I think they must mean only nurse practitioners, because we have no opted out doctors who sign off on the services done by nurses. And I think that the tasks that you can go to their website, I think that the tasks that they offer are within the scope of practice of nurse practitioners in Nova Scotia. Now, interestingly, Algamed also notes that, and I quote here, our goal is to create the world's first autonomous physician with artificial intelligence, which, so get rid of the flesh and blood physicians altogether, which might in fact be the long-term game plan for avoiding physicians in their facilities. Isn't artificial intelligence wonderful? Amazon Prime's top pick for me last week, speaking of artificial intelligence, using their algorithms, the top pick for me last week was Women Who Kill. And now my husband wants to know exactly what kind of information Amazon is using in its algorithm. Okay, next column, opted out MPs. Are they limited to the public fee schedule? So here's a key way in which some provinces restrict private healthcare facilities without actually outlawing them, right? They simply say, okay, fine, work outside of MSI if you want, you simply can't charge more than MSI's fee schedule, right? And in the smaller provinces, it's hard to make a go of it financially unless you have the numbers. Of course, you would have to charge more to be financially viable. But in the larger provinces where you do have the critical mass, this provision probably wouldn't prevent a clinic from being financially lucrative in a large urban area. Okay, direct prohibition of use. Now, this column is about to get really interesting. So the Canada Health Act prohibits extra billing and user fees. So if and when user fees are identified in a particular reporting period, these funds are then clawed back by Ottawa on the next set of transfer payments. Now, while this has been applied to user fees and extra billing for medical services for some time, it now applies also to medically necessary diagnostic services. So the 2018 Petitpas-Taylor interpretation letter stated that this new diagnostic services policy would come into effect in 2020. And the deadline for the first round of reporting on any private diagnostic charges for medically necessary tests is, in fact, next month, so December 2022. So we may see some real change in the clawbacks reported in this column in the next report. And Nova Scotia is one province to keep your eye on. Remember, at least before COVID, when you could just go to a private MI clinic and get an MRI done for about $800 out of pocket? Well, if that's still been happening in 2020 and 2021, then Nova Scotia will have some serious clawbacks in its next check from Ottawa. And the same is true from Saskatchewan, where they have this bizarre one private, one public MRI system. So keep your eye on that. Quebec refuses to make it easy for Ottawa to calculate the information, so we don't really know. Now, so have a look. Nova Scotia, 0, New Brunswick. New Brunswick, they actually had a deduction here, but it was for 2018, 2019. It's for an abortion clinic. But 0, 0, 0, 0, 0, and BC, oh, look, $14 million. So you can see how lucrative these services are in BC. That kind of stands out here. The reason for this amount is that in November 2018, there was a BC Supreme Court injunction prohibiting the enforcement of the extra billing provisions until 2020. But now that the dust has settled around Cambie, BC has enforced its extra billing provisions. And so Ottawa has actually reimbursed most of these clawed back funds. Next column, prohibition on dual or duplicative insurance. Again, this is a key provision. It's often assumed that this is established under the Canada Health Act, but in fact it is up to provinces, and some of them do not prohibit dual insurance. Ontario and BC do, and that was one of the key issues in the Cambie case. While Quebec allows dual insurance in some areas, but not others. Came in the wake of Charlie, and Nova Scotia does permit dual insurance. Well, interestingly, Alberta, that libertarian province, does not. Prohibition on dual practice. In most provinces, you have to decide whether you're in the public or the private system. You can't be in both at the same time. Note that provinces that generally do allow dual insurance and dual practice are the small provinces where private practice would be much less financially lucrative. So the more demand there is, the more provinces have to formalize barriers to private practice. And finally, this is kind of interesting, perhaps commingling. Here's another way to make life harder for private, or easier for private clinics. If you allow private and public physicians to work in the same clinic, the business model is stronger, right? As you can depend on the public sector when you don't have enough private patients. It's sort of like flipping the switch from AC to DC. But if you can't do this, it makes the business model a lot more tenuous. So take-home message here is that there are a number of different ways you can either limit or support private healthcare, and that almost all of them are at the provincial level. Again, in Nova Scotia, physicians are free to set up a private clinic. They're free to work outside the public system. They're free to access private health insurance, even for publicly insured services, if that is the kind of business model that they want. So if you think there should be a private healthcare system in Nova Scotia, go for it. The thing is, you can't simply and easily fall back on the public teat if business isn't as robust as you'd hoped, but then that's the private sector, isn't it? So as usual, the debate over private health care provisions usually assumes that the audience is from Ontario, where the laws are in fact more restrictive, but one could still ask whether these various provisions in the respective provincial laws should or should not be eased to accommodate more private healthcare. So again, we get back to the question I asked right at the outset, which is, what does it mean to privatize healthcare in Canada? And of course, the answer is, in good Canadian fashion, it all depends on the province that you're in. So you have a lot of options depending on your existing legislation. Okay, so we've got 50 minutes left. Okay, so we now come to the question of whether provinces, in fact, should revisit some of these legal barriers, especially where there is a critical mass of those willing to pay. And the argument that is generally given is the easing the burden or the improving access argument. And this argument is that by allowing the private purchase of publicly insured services, you're taking the pressure off the public system. So if I want to buy a knee replacement next week, I'm sure it'll be fairly soon when I do need one, it just gives my public spot to somebody else behind me in the public queue who cannot or will not pay the $26,000 that I was quoted for such surgery. But again, things get complicated here very quickly. So all things being equal, having, say, 700 of those knee replacements done privately would free up another 700 spots for those who can't afford the $26,000 a pop. The problem is not all things remain equal. So changing the policy ecosystem puts a number of new dynamics into play that all begin to lead over time to what economists like to call negative externalities. And this is probably why there is no convincing evidence that opening up more private healthcare has a clear and direct impact in shortening overall wait times. So both Australian and British studies have found that allowing surgeons to work in both public and private sectors actually lengthened public wait times, and similar results were found in Manitoba. So there simply isn't any really good data to argue that opening up private healthcare actually lessens wait times. The only simple magic bullet for lessening wait times is more money in the system. And then, yes, I know you have other kinds of negative externalities. Okay, what are some of these dynamics? Well, one thing that we've been hearing a lot about is the likelihood that increasing private facilities would pull healthcare workers, and not just physicians, but OR nurses, anesthesiologist, so on and so forth, away from the sector, thereby making public wait times longer. Then there is the issue of cream skimming, where private providers like, private insurers only take on the easiest and the most straightforward cases, leaving the public system to support the harder and more complex cases, thereby essentially shifting costs onto the public sector. There's also the argument that some players tend to game the system. So a private system essentially needs long public wait times to attract patients and make money. And in this way, some physicians working in both the private and public system have a perverse incentive to make their public patients wait longer in order to encourage them to access the private systems. The more effective a parallel private system reduces overall wait times, the more it actually threatens the very point of having a parallel private system. Then there are those who, in the quest for profit, engage in overtreatment. Oh, you've got a sore back. Well, yes, then you really do need to have back surgery, right? And that's why the American system is so dysfunctional. It both under provides care for those who need it the most and over provides care for those who are largely healthy but somewhat neurotic. Now, this feeds into a related point. By definition, many of those attracted to private for-profit healthcare are going to be those who, by definition, are interested in profits. And where are the profits in healthcare? Well, if you want to provide healthcare for profit, you cater to those who have disposable money. You cater to the worried well in the upper socioeconomic brackets and not those who live in the streets. So you do full body scans for rich, anxious people rather than diabetes care or mental health care for the people on the street, because that's where the profits are. Obviously, profit margins are higher when targeting wealthier people who statistically have less need for most services. Another interesting point, the public sector has to put considerable resources into regulating a private sector to ensure that unnecessary treatments or tests aren't done or that unnecessary costs aren't incurred. Now, if you read the Canada Health Act report, which asks provinces how they know that no hanky-panky is happening, you'll see that much, if not most, if not all, of the oversight is actually reactive. It's based on complaint rather than on monitoring. So, that's with a very small private sector. Imagine the regulatory costs imposed on the public sector if private healthcare exploded in size. The last point is what social sciences call decommodification. So in the long term, the more that well-off people gravitate to a private or commodified system, the less likely they are to support a well-funded public system, right? If I send my children to private school, then I don't want to keep shoveling my taxes into the public school system. I want to diminish them as much as possible. And of course, those who gravitate toward the private system are also the people who are the most politically active and who are in a position to change the system. There are other concerns that we can talk about. One is sustainability. We know from both CI-HI and international data that private healthcare costs tend to rise more quickly than public ones. And one reason for that is that when the state has skin in the game, they tend to be more willing to use their regulatory powers to keep costs down, such as pharmaceutical costs. We also know that administrative costs are higher for private healthcare, and one study by Hurley and Wyndon notes that administrative costs for public health insurance is 1.3%, whereas for private health insurance is 13.2%. There is also the normative question of the extent equity should play in accessing services. No economic answer can be given for that. Do we want two tiers? And of course, a lot of Canadians will respond, well, I'm all in favor of equity, but not if it means that we are all equally unable to access good care. And therein, of course, is the problem. All right, so the argument that more private services for some makes public services for the rest more accessible is attractive on its face. But it becomes more like Pandora's box the more one digs down. Is it at all possible that certain forms of private care insurance or provision could be harnessed within a provincial context in such a way that they might provide options without opening the door to a tidal wave of negative externalities? Well, if someone can make a detailed and coherent argument showing how this could work, and if they systematically addressed all the issues I raised here, I think we really should do them the service of listening and to think carefully about it without getting hysterical. Now, I have to say, I haven't seen any thoughtful strategy that convinces me that of all the options open to us, there is, in fact, a mode of private care that would actually solve more problems than it created, but who knows? Maybe somebody will, and if that happens, we should, I think, be more open-minded and think through these suggestions carefully. So the next time that you hear the argument that we need more private healthcare, I'd suggest that you ask the following questions. First, what exactly do you mean by private healthcare? And bring in the bunny ears if you feel free. How is the proposal situated within the legal structure of each individual province? What is your evidence base for the claim that such a move would be advantageous, both immediately and in the long run? Who do you think the winners and the losers in such a reorientation would be? And knowing that, could you live with the results? So, thank you very much for your time, and I look forward to your questions.
I don't know if we can unmute everybody. I'll clap for everybody. Katherine, thank you so much. That was a lot of stuff to think about, and I'm just the word that came into my mind was sort of you've been a great myth buster, because I think a lot of us hear things and we really don't know how to interpret and process and sort out this tough topic. So it is right. You're right on time. You're a polished lecture deliverer, I can tell. On our schedule here, Katie, we have a break built in to stretch legs and things. So why don't we do that? And Katherine, you can get wet your whistle a little bit, and the rest of us stretch our legs. Maybe come back 15 minutes or so. Katie, is that good? Say it at 7:30. Is that what's on the list? Say 7:30. Is that good?
Yep, that's great.
Okay. And in the meantime, keep putting your questions into the chat, and Sam will sift through those and bring some back when we have time. So see you in 15.